Hi everyone. Today we'll be discussing diabetes complications and in particular Charcot foot. Charcot foot or Charcot neuroarthropathy is a progressive non-infectious disorder characterized by breakdown and fragmentation of bones and joints in the setting of peripheral neuropathy. Most commonly in the setting of diabetic peripheral neuropathy, given the increasing prevalence of diabetes mellitus. Although it can affect any denervated joint, it most commonly involves the foot and ankle, hence the moniker Charcot foot. The disease typically progresses through recurring episodes beginning with inflammation and advancing through joint destruction, bone coalescence, and eventual remodeling. This process can result in significant deformity and complications such as joint instability, ulcer formation, and because diabetics have impaired wound healing, infection, and ultimately, in severe cases, amputation. Early acute Charcot foot typically presents as a warm, red, swollen foot, sometimes accompanied by a history of trauma, pain, or even early deformity. Clinical manifestations vary according to disease stage, ranging from mild swelling to pronounced edema with visible bony deformity. Peripheral pulses are usually intact, and clinical evidence of peripheral neuropathy is almost always present when you conduct your lower limb sensory examination. In the presence of intact skin and loss of protective sensation, these findings are characteristic of acute Charcot arthropathy. It typically is a clinical diagnosis and should be suspected when a patient presents with any of these characteristic symptoms. Initial plain X-rays may appear normal, but later imaging can reveal fractures, bone resorption, joint reorganization, subluxation of the metatarsophalangeal joints, and dislocation of major foot joints. Although reduced sensation is present, pain is often reported, which may seem paradoxical given the profound peripheral neuropathy these patients typically present with. A triggering event such as minor trauma or repetitive microtrauma is thought to initiate the condition. However, when you take your medical history, many patients do not recall an inciting injury due to the aforementioned sensory loss. If the condition is untreated or diagnosis is delayed, two characteristic deformities may develop. A rocker bottom deformity caused by downward collapse and displacement of the midfoot, and medial convexity. Typically, the medial aspect of the plantar arch is nice and concave. However, in Charcot foot, due to talonavicular displacement and tarsometatarsal joint dislocation, you lose that concavity and it becomes convex, which predisposes patients to ulcer formation due to the pressure placed on the foot when ambulating. Now, this is what a patient may present with. You can see that there is unilateral swelling in this foot. It is most likely warm to touch, and along the medial aspect of the plantar arch, there is loss of the concavity and it is more convex in nature. Here's an idea of what is most likely going on inside that joint. So you may have fusion of the joints, you can have bony fragmentation, you can have deformities like the rocker bottom deformity. All these will serve to impair the normal arch of the healthy foot and predispose patients to ulcer formation. Now, in terms of the pathophysiology, there are two proposed theories. The neurotraumatic theory, where there is loss of protective sensation and proprioception leads to repeated unrecognized microtrauma. The resulting inflammatory response causes bone resorption, weakening of the joint, and increased vulnerability to further injury. There's also the neurovascular theory, where there's loss of sympathetic nerve function which leads to increased blood flow to the foot. This stimulates osteoclast activity and accelerates bone turnover, making the bones more vulnerable to injury. In terms of the etiology, Charcot foot is not simply a disease of diabetes, it is more so a disease of peripheral neuropathy. So any disease that causes impairment in peripheral sensation, proprioception, or fine motor control can predispose to neuropathic joint disease. So that would be diabetic peripheral neuropathy, alcohol-related neuropathy, syphilis, spinal cord injury, myelomeningocele, syringomyelia. Finally, let's talk about the management. So the management aims to prevent skin breakdown, maintain joint stability, and preserve a plantar-grade foot. Offloading and immobilization during the acute phase are essential to limit further joint damage. This is typically achieved through total contact casting, which is considered the gold standard, and essentially involves enclosing the foot and lower leg in a specialized cast that redistributes pressure from the foot to the leg, restricts ankle movement, and minimizes shear forces, allowing healing to take place. Casting is continued until swelling and the increased temperature have resolved, after which patients usually require custom-made orthotics to accommodate any residual deformity and reduce the risk of ulceration. Occasionally, in very severe cases with severe joint destruction and deformity, surgical intervention may be warranted.